I understand that kidney cancer is greatly underfunded and that it's not really understood. Could you share the details surrounding that with us?
Most common cancers that typically are being treated by oncologists are lung cancer, breast cancer, colon cancer, prostate cancer. These are the big fours, if you will. These are the bread and butter of most oncologists. Kidney cancer is still among the 10 most common cancers, but it is not a very common cancer. So most oncologists see maybe 1 or 2 kidney cancer patients per year, and it is not the most common cancer that typically attracts funding opportunities. So kidney cancer is underfunded, and I think an objective measure, for example, is if you compare it to melanoma, which is a cancer that many talk about, it is clearly underfunded in the range of roughly 5% of what funding for melanoma receives. So this is really a disease that deserves attention, and where we can, I think, make a real difference if we can attract funding opportunities.
I've heard talk about seed money and the connection between raising that and then opening the funnel for much larger grants. Could you explain that?
Yes, this is an outstanding question. So the truth is that there is actually funding available for research that the government provides. The problem is, how it is being distributed, and the issue is that government agencies are fairly conservative with regards to who they give the money to, and it is required that you have a certain amount of initial data before they give you more funding to support your research. And this is where seed money comes in. It is important to have money available to get the initial data that would support the application for larger grant funding. So an example is, for example, that you start with, let's say, $50,000, $100,000, and you may be able to get a data set that allows you then to apply for funding that is in the $1 million to $3 million range of federal funds. So you can leverage initial philanthropy. So if you get seed money in that range, you may be able to get data that where the government then says, well, this is actually worth investing in, this is not too risky for taxpayers, and where you may then leverage essentially the initial investment.
That's very exciting. And what's also exciting is some new combination therapies that are poised to really change the landscape in the treatment of kidney cancer. Could you explain those to us?
So I think the one topic that is now in everyone's mind when we think about cancer therapy is immunotherapy. This is something that we have tried as a community for 30, 40 years. I would say many of my colleagues were ridiculed who were in this field before, simply because it never worked until I would say we had some critical insights that taking the brakes off the immune system can make a major difference. And what you're seeing right now is literally a revolution in oncology, how we treat cancers. The idea of taking the brake off the immune system to use the patient's own immune system to go after cancer and use it as a living therapy, if you will. This is really something very new and very exciting. A component that is most striking is that if you respond to these kinds of new therapies, you may actually respond for long periods of time. This is something very different than what you see with targeted therapies, which often only works in the range of several months. If you do well with immunotherapy, respond to immunotherapy, often those benefits can last in the range of years. Cure is a strong word, but I think this is what immunotherapy intends to do, is eventually to be good enough to tell patients, well, we've had a major effect. I think we can hopefully think about your disease being addressed for good. This is certainly the goal of immunotherapy, and I think these are really exciting times. The currently approved drugs in immunotherapy, as exciting as they are, they're not good enough. I think they're a good basis. We need to combine them with other therapies. We need to educate the immune system better. And I think if we work on different aspects of immunotherapy, we can make a real difference.
And is it true that the types of treatments that are required to get a handle on this disease are extremely expensive, and that is why we must focus on new ways to raise funds and to draw attention to raising the seed money.
Therapies are expensive, new therapies are expensive. I think it's important to figure out which combinations make sense, what are rational combination strategies, rather than aimlessly putting new therapies together or very expensive therapies together. I think it's important to understand why certain patients do benefit or don't benefit from certain therapies. So I think biomarker development, rational development of certain strategies to analyze someone's cancer and say, well, maybe a combination of A, B, and C is going to be better than D, E, and F. I think these are going to be all important aspects of how we move the field forward.
And these therapies that we've been discussing that are a new generation of treatments offering hope, those have already garnered some impressive results. Is that right?
Absolutely. You almost an unprecedented approval rate of these drugs by the FDA. So even agencies that we think of that are rather slow-moving, conservative when it comes to approving new drugs, once they see the new trial results coming in, they often approve drugs fairly rapidly. An example is Opdivo or nivolumab in renal cell carcinoma. The data became available, and literally, I think within 2 weeks or so after filing, the data said with the FDA, the drug became approved for kidney cancer patients, which was rewarding, and I think was really a success story in immunotherapy for kidney cancer.
Thank you so much for being with us, Dr. Hammers.
Absolutely. Thank you very much.